Good afternoon. My name is Anchali Avihing Sanon from the HIV-NAT Thyroid Cause AIDS Research Center. So I would like to welcome you to this section. And Napon Hiranburana is also my co-moderator for this section. Today we have such a great team from the panelists. You can see here. Maybe you just show the slide. Oh, okay. So first from the right, on my left hand. So Dr. Opat Pucharan. He's an infectious disease from Faculty of Medicine, Chulalongkorn University, and also with the Thyroid Cause AIDS Research and Infectious Disease Center. So the second panelist from Dr. Ong Heng Cheng from he also ID physician from the University of Malaya Medical Center from Malaysia. So the third very beautiful women here is the Sivaporn Ket Chumpon, the ID physician from Faculty of Medicine, Ramathipodi Hospital, and then Dr. Iriet Lesis from the Division of Global HIV-TB, Global Health Center, and US, and then Gail Matthews from University of New South Wales and Kirby Insteel, Australia. So we have diversity of panelists from high-income country and then to low-middle-income country. So we're gonna discuss. So for today, so it's different from yesterday section. So we would like to get or to know their opinion. And also, I would like this section as interactive section. So from the floor, if you have question or if you have some comment, just feel free to raise your hand and to speak out. We will start with the first interesting case. So the next slide. Oh, before going that, so similarly to the debate, we have the vote. So just look at your the back of your badge for workshop number 1, and then you can scan, okay, and then vote on that. Okay. Next slide, please. So let's go with the so we have 4 interesting cases today. So start with the first case presented by Dr. Napon. Napon, please.
So, good afternoon, everyone. I will start with the first case. So, this case he is a heavily treatment experienced people with HIV. So he was referred to our HIV-NAT clinic because of the recruitment of the drug-resistant trials. So he was treated at other tertiary hospitals. So for the brief information here, he is a 39-year-old male who is MSM and works as a chemical factory worker, which required to do the night shift, and he was not in a good adherence at all. He was diagnosed since 2012 with a CD4 count of 339, and his current ARV is TLD, which is the third line. The DTG exposure duration was total around 2 years. Also, he was experienced the first line is the inhibitor, which is a raltegravir for 2 years. And last year, he was diagnosed as a pulmonary TB and treated with the HRZE standard regimen. At that time, the raltegravir doses increased to 50 milligram BD doses. And now his CD4 count has been dropped down to 26 cells per ml. So next slide is the trajectory of his viral load for over his treatment courses. After he was treated for 3 years, he started to have a virologic failure, which at that time he was using the second line already. It is a lopinavir TDF-SCT for around 4 years with the volatile of the non-suppressed viral load. After that, the regimen was changed to darunavir, ritonavir, TDF, and raltegravir. During that time, the viral load was suppressed, and he lost follow-up between these years. After the COVID pandemic, he lost his job and come back here in the 2021 with a virologic failure. At that time, the regimen was continued as the same, which is the raltegravir, darunavir, ritonavir, and TDF, which result in non-suppressible viral load in a year. So at that time, the viral load was around 100,000, and the genotypic drug resistant test was done, and the result is here. You can see that he have many major drug-resistant mutation for the protease inhibitor classes, which result in the highly resistant for nearly all of the class. But the RTI and INSTI resistant only occur in minor mutations. After that, the regimen was changed to lopinavir and TLD from the primary physicians, which result in rapid decline in viral load in about 2 months to 100 copies per ml. But after that, for about a year, his viral load started to incline slowly to about 20,000. At that time, he also have tuberculosis infections, which required the increased dose of DTG at that time. After the TB regimen finishes, the LV was changed to TLD. That's when the patients came to our clinic. And this is a trend of his CD4. You can see that his CD4 is dropping down rapidly in 2 time period when he used the second regimen and when he lost follow-up in the COVID pandemic. So here come the first questions. Which regimen will you use while waiting for drug-resistant results? Because in Thailand, we may have to wait a long time, maybe 1 or 2 months before the drug-resistant result in INSTI resistant come back. So whether you continue the TLD or you use the darunavir, ritonavir, DTG, BD doses, and 2 NRTI. Or if you don't have any barrier, you can use lenacapavir and cabotegravir, ripivirine, or injection regimen. Or you just add the lenacapavir with the DTG, BD dose and 2 NRTI. Or you consult this guy. You can vote now. So, we all continue the TLD and or some may change the regimen to darunavir, ritonavir, and DTG, BD dose and continue the recycle the 2 NRTI.
Okay, so let's see the opinion from panelists who want to go first, or maybe just you, just sit next behind me.
All right, thank you. So in my opinion, I think the patient has multiple occasions of non-adherence because when you look at the history, when he was on effective ART, sometimes the viral load going up to above 50,000 copies per ml. indicating that he might non-adherence to the treatments. So the first thing to manage this patient is to talk about adherence, why he has this problem. Because if you switch, if he's still non-adherence, he's gonna fail the next regimen. So I think that in my opinion, I will stick with the TLD and wait for the resistant testing results, and then talk about the adherence. What are the barrier of taking the medicine, and then modify the treatment regimen again after we receive the genotypic resistant testing.
Dr. Ong, do you have any?
Hi. Yes, I agree with Professor as well. We have to explore the reasons of the patient being not adherent, being the main cause in many occasions. And back home in my country, in Malaysia, all the medications actually comes with a cost that is not cheap and not affordable by all of them. So it's not as easy to say like we change regime and it happens straight away. There's a lot of financial challenges as well. And if they are not being adherent with the new regime, then we may face with a new resistant problem in the near future. Yep.
Yeah, I agree with true professor, because the adherent you can see in this graph of his viral load that he has many episodes of non-adherence. So we should explore the adherence first and then repeat the viral load and that resistance testing, and we go with the TLD.
Okay, thank you. So maybe I just go with Gail first because Elliot gonna show some slide.
Yeah, look, I sort of completely agree with the panelists. I mean, that his adherence is going to be key. I mean, all the guidelines will say when you're going to change to a regimen, you want to have at least two active drugs, right? So you don't know what's active at the moment. Long-acting injectables will be great for this patient potentially if you've got something to add with it, particularly. So lenacapavir, we have lenacapavir on compassionate access now in Australia. We probably have 7 people on it in the country, so it's not a big problem. These people are really, really heavily drug experienced, so you can't make a regimen for. But you would want to be able to give it with something. I don't know whether you can get Maraviroc, whether it's worth doing a CCR5 test for him as well, see if he's got that option. Obviously, he might have the M184, which is kind of going to sensitize him, even if he might be resistant. So you might be able to concoct something. The worry I'd have about keeping him on TLD is his CD4 count's 24, right? So he's not somebody with a CD4 count of 300 that you can kind of wait a little bit. I mean, he's going to need something pretty quickly. So I think it's complicated, and I think it's a real shame for most of the patients that we see, I have to say, do not have darunavir resistance. I mean, it's much less likely to get darunavir resistance. So he's very unlucky that he's got that, and DTG probably resistance as well. So he's in a problem.
Okay, thank you very much. So you want to show next slide first, and then with.
So while waiting for the result, the primary physician changed the ARV to darunavir and double dose DTG along with the TAF and FTC. And this is a comeback of a drug-resistant mutations resulted. You can see that from the RTI perspective, he had developed the new drug-resistant mutations for both NRTI and NRTI. And interestingly, in the protease inhibitor drug-resistant mutations, after not using PI for 2 years period, his major DRM decreased from 5 to just 1 mutations. Only is out 26 weeks. And for insti resistant, there is many major drug-resistant mutation to be shown here, and it causing the high level resistance to all insti. So after the regimen was changed, the viral load come down to about 6,000 copy per ml. So this is a graph of his CD4. So he is still in the advanced HIV stage, and with the I don't know whether it is suboptimal regimen or not. So here come the another questions. What factors possible contribute to the second generation instead resistant in these patients? From your opinions, is it a previous first generation instead exposure, or drug interaction with the rifampicin, or suboptimal treatment regimen, or his advanced HIV stage? Or you can choose more than this. So let's vote. So almost all of them think it is a suboptimal treatment regimen.
For this, so why is a suboptimal regimen? Just go back to his regimen right now. Okay. So any comment from the panelists? So what should we do?
So I think there are two reasons. The first is the suboptimal regimen, because when you look at the resistance pattern, the patient already have a resistance to protease inhibitor. But in this slide, showing that there is only one mutation, but actually the fitness of the virus that resists to protease inhibitor is really low. It doesn't mean that they have only one. There might be some archive resistance that hiding and tend to increase over time when you continue failing regimen. So the other factor is the patient has been exposed to raltegravir, which is the first generation integrase inhibitor, and the patient already might fail from the duration of the the past exposure of raltegravir, and then there were some accumulation of the mutation that resist to raltegravir and cause cross-resistance to dolutegravir. So there are multiple factors that can explain in this case. This is my opinion.
So any comment? Okay.
So do you have explore any concomitant drug?
He used calcium supplement, which
which is have a drug interaction
yes.
with the DTG, as we know. Okay, maybe probably the DTG level in his but is suboptimal as well. So that's why he developed integrase resistance.
Okay, so just for the floor, so as all our panelists mentioned, so about adherence, and also another thing that to be concerned is about drug-drug interaction, especially with the dolutegravir. And so this patient, he took calcium, right? And with the calcium, it decreased the dolutegravir about almost 50%. So when you want to use with this, you have to split to like a 2 hour before taking BCG, and also or 6 hours after. Or if it's very difficult, just ask the patient to take TLD with food. Because with food can increase the DTG concentration about 30 to 60%. So actually for DTG, it doesn't require meal, but if you don't know whether the patient take over-the-counter drug or not, it's better to ask them to take with food. Okay.
Again, I would like to emphasize what Dr. Anjali just mentioned, because this is a very difficult patient. We need to make sure that the level of the medicine is enough to control the virus. Usually, dolutegravir can may not taken with food, but in this case, we need to counsel them that the medicine should be taken with food because we don't want to fail anymore because this might be the last chance of getting the best affordable regimen for him before we move to lenacapavir or the other expensive options.
So, Edith, do you have any comment? You want to present? Yes,
I can. You want me to present from here, from the comfort of my seat, or do you want me to go up there?
It's up to
Okay.
you. So,
No, I'll say that. I'll present from the comfort of my seat. Now, so I don't know about the other panelists, but I had the advantage of getting to review the case in advance and think about it. And so because I was limited to how many slides, I could have had a 40-slide presentation just on this one patient, but I limited to slides. So anyways, I asked, so in my mind, as I was reviewing the case, I sort of thinking about if the patient was right across from me, I would be wanting to ask, a lot of important questions. But I think what all my co-panelists have brought up is that first question is probably the most important question, which is how did this happen? Okay, getting to the adherence pattern, getting to the drug interactions, sort of keeping it simple from the standpoint of not even getting to what the drug resistance pattern is and all that, but just understanding that you can have a conversation with a patient and find out how this happened without the convenience of drug resistance testing, drug level testing, which can be done in some places. And so I think that, I think the co-panels have really have emphasized that in their comments, and so I agree with that. And so I think, and then I guess the other thing that comes to mind, especially with what Gail said about, having 2 active drugs, and I did see a lot of regimens in there that probably had 3 and potentially even 4 thought to be active drugs. And I think one of the things that I like to think of when I think about this is, do I really want to give the patient more drugs that they cannot take? Okay, if you understand what I'm saying. So in other words, I do think we want to keep the regimen as simple as possible, recognizing that adherence is a challenge for this patient. And so I think sometimes we have this tendency to think, well, one more drug will be better. But I think we also have to recognize that one more drug just might be another drug that just sits in the patient's closet and never gets taken. So I think that we want to keep it as simple as possible. And so that's the one thing I would say. So going to the next slide, in terms of how did this happen, and Dr. Kumar had a nice slide yesterday. This is just some other approaches you can look at this. I think, in terms of, he had the slide on how drug resistance occurs. It's going to occur when you have suboptimal levels of drug in the presence of viral replication. That's pretty much what he was saying yesterday, and that's just what these are just other ways of visualizing that. So how did this happen? As I said, you want to find out from the patient, but then here's some science behind how this happened that I think you could keep in mind when you're choosing what the next regimen is. You can go to the next slide. So then the other interesting thing I thought in this case that maybe hasn't come up yet is the fact that the patient had this low-level resistance to tenofovir, which was manifested by the D67N and T215Y. And we don't see it as much as we used to because we have so much less use of AZT, and before that D4T and other drugs that tend to cause TAM. So we don't see this phenomenon as much. I do think that for some reason, I'm not actually sure why, but for some reason the patient probably had these TAMs based on the AZT exposure years ago and was archived, and for some reason that came out in this most resistant drug resistance test. I think the question really now to ask is, does that mean anything if we're going to do a tenofovir-based regimen? And I would be inclined to say no. I think I would safely count tenofovir as one of the active drugs in the regimen. It's according to the Stanford database, at least, it's less than 1.5-fold decrease in sensitivity, which I think in efficacy, which I think is or potency, excuse me, which I think is okay to give in this setting. So I would consider tenofovir in the setting of those two mutations to be an active drug. I also, M184V has been brought up, and I think it's really interesting that the patient has somehow never exhibited an M184V, which is something I would have actually expected. So has not, sorry, staying with that previous slide for 1 second. So I don't really understand why the patient has not, but if the patient did have a 184V and might, it's just archived right now, that actually reduces the tenofovir resistance even further. Next slide. So, I think that the question of the double dose dolutegravir, there's all sorts of controversies about double dose dolutegravir. I think the two places that I've actually seen double dose dolutegravir discussed most often has been in the presence of integrase mutations. So the question, and especially some of the raltegravir-induced integrase INSTI mutations that we've seen that have already been mentioned, and whether doubling the dose of dolutegravir is enough to overcome that that disadvantage that they're getting from the raltegravir-induced mutations. But then the other place would be in interactions with rifampin-based regimens. Another very strong drug-drug interaction that we have to be concerned about that probably comes into play with this patient. And I think, but a recent study does suggest that there wasn't that much improvement in the use of the second dose of dolutegravir in the presence of rifampin. So I think, again, getting back to that principle I said is let's avoid giving the patient more drugs to not take. I think I would not be surprised if many, many patients in the world who are prescribed twice daily dolutegravir only take the dolutegravir once a day. And so I think that, and in this study at least suggests that might be okay. And so I think, so I don't know what the advantage of the double dose dolutegravir is. Now in retrospect, you had so much INSTI resistance at this point in time that I don't know that there's any advantage to dolutegravir at all in this patient. And once I saw the mutations, I probably would have been inclined just to drop the dolutegravir completely. I understand why it was put in empirically pending the drug resistance results, but maybe just the tenofovir FTC with darunavir, probably twice daily darunavir because of the history of PIs that was already mentioned. But, and again, that gives them an opportunity to have another drug they don't take, but I still think that might be important. And so, but I'm not sure we have an advantage to dolutegravir in this case, and it might be best at this time to just, unfortunately for this particular case, give up on the use of dolutegravir. Next slide. So lenacapavir has already come up, and just to remind you of how we use lenacapavir, Gail mentioned it. I think we actually use it more in the United States than what you described. And I certainly have a little bit of experience using it myself. The thing I want to point out in this that is missing from this study, this was the seminal study that caused the release of lenacapavir for these situations where you have very little options with other drugs, is that this study was optimized background regimen. So we've just been discussing what would be an optimized background regimen and then adding lenacapavir. The thing that always concerns me is that we can assure ourselves of the adherence or lack of adherence to the injection, because if they show up for the injection, we know they've gotten the drug. We don't know about them taking the oral optimized background regimen. So I think it's always something that we have to be concerned about if we're going to be prescribing lenacapavir, even in settings where you have lenacapavir available. So that's my take-home message about lenacapavir is it might be good, but I'm worried that if you don't have a good optimized background regimen that the patient's going to take on a regular basis, then you may eventually fail with lenacapavir resistance. Next slide. Okay, so those were my slides.
So just like to ask you, I'm sure that many countries cannot access to lenacapavir. As you work for PEPFAR, how you can help us to get like a cheaper or affordable lenacapavir?
Yeah, so what I probably can feel at liberty to say about PEPFAR and lenacapavir is that right now our primary focus for lenacapavir is for prevention, not for treatment, okay? But of course, lenacapavir is going to be lenacapavir whether it's for treatment or for prevention. So for example, if Thailand or any of the other countries that you represent is one of the countries that gets early access to or medium-term access to lenacapavir for prevention, and you have these, difficult cases, there's, you may be able to, at the same price, give the lenacapavir for the treatment, again, depending on what the optimized background regimen would be. We are starting to discuss what kind of injectable, like Gail was mentioning, injectable-only regimens could be combined with drugs could be combined with lenacapavir. I think the best candidate right now is cabotegravir. I don't think cabotegravir is an option for this patient, but I think that lenacapavir-cabotegravir combination makes perfect sense. But unfortunately, it's never been studied in any kind of clinical trial, whether it's a comparison trial or even an open trial. There was a recent report out from the United States. We have a number of patients in the United States, because we have both drugs available, that are receiving lenacapavir and cabotegravir, sometimes with rilpivirine, sometimes without. And we've seen pretty good viral suppression when we've been using that, and those are scenarios where we just don't trust the oral regimen as an optimized background regimen. So I do think that we need the studies, and we are looking at starting some clinical trials, but those are going to take several years to come out. So it's going to take a while to have the evidence for what the ideal regimen, injectable regimen would be. But I would say right now, lenacapavir, cabotegravir is the most promising regimen we have. Unfortunately, that's lenacapavir subcutaneous once every 6 months. That's cabotegravir IM once every 2 months. Maybe we'll be able to get away with once every 3 months. I doubt every 4 months. And so those are things that we're looking for, and I feel like we need more scientific evidence to support.
Okay, thank you very much. So the regimen that cabotegravir plus lenacapavir, I think is in a plan for the ACTG study. So we should try to bring that study to Thailand, Philippines, India, and Vietnam as an international site. So then we have that experience. Okay, so we don't have that. Any comment from the floor? Yes, Peter.
Peter Rice from Amsterdam. Just a general question to the panel about lenacapavir prevention versus treatment. Does any one of you feel that it might be good to reserve the drug primarily for prevention and in the treatment space for patients like the ones that were discussed, rather than opening it up widely?
I mean, I'll start, Peter, thank you for that. We definitely have discussed that. I think that the lack of transmission in the lenacapavir studies is really impressive, because if you don't have transmission in the face of lenacapavir, then I think you don't have to worry about lenacapavir resistance. Now, having said that, I can pretty much guarantee we will have transmissions once we roll this out in any kind of programmatic setting, and we might have transmissions with lenacapavir resistance. If we had other alternatives for long-acting that we felt like were in the horizon of being able to set up a study and have the results of the study available to us in the next 3 to 5 years, then maybe we could apply that principle that I think is an important one that you suggest. But unfortunately, we don't have a lot of good ideas out there. Islatravir was a drug that we were hopeful about, but it doesn't seem to be panning out for long acting, maybe shorter acting. So I think that right now, I think the need for an injectable regimen for these kind of scenarios probably outweighs that concern, even though I do think that's a valid concern.
Thank you very much. So just for the floor, so now we have a long-acting injectable ART. So in near future, we're gonna have the long-acting anti-TB. And another thing is long-acting hepatitis C drugs, maybe just one shot for hepatitis C drug. Just stay tuned for that study. Kumar, you want to make any comment on this case?
I think Elliot beautifully, summarized in his slides, what are those, we unnecessarily double the dose of DTG and induced mutation. I think we also learned from the DEP study, tenofovir, lamivudine, and darunavir, could be an alternative. Here that we recommended for second line, but again, in difficult situations, I think darunavir twice daily, along with tenofovir, should be something I think should be the option to rescue, such patients. And of course, lenacapavir, we can continue to argue, when we are going to get this. But one thing is there is a capacity building transfer technology from innovator to few Indian generic companies. There are a lot of constant dialogues going on. It may take another couple of years. So I'm sure it will be available. It may take some time. I think till that time, we have to deal with current regimens. I think tenofovir, lamivudine, and darunavir twice daily probably could have been the option for this particular patient.
Okay, so thank you very much. So maybe just move on to the second case. Yes, just go with the second case.
So let's change the theme to advanced HIV diseases cases. So here's summary of the case. He is a 30 years old Thai male with MSM. He's a soldier in the east side of Thailand. He now presents with a fever for 2 months. For 9 months before admission, he had a non-itchy purplish rash on the leg and spread to arm, trunk, and back with no other symptoms. And 2 months prior to admission, the purplish conjunctival nodules seemed to appear along with the dry cough and intermittent evening fevers. And for 1.5 months, the enlarge of the conjunctival nodules obstruct his visions, and there is a new eyelid nodules, and along with the persistent fever, dry cough, and he went to the first hospital. Concerning for his cough, this is chest X-ray showing the ground glass opacity, which seems to be predominant in the right upper lung zone and right middle lung zone. At that emergency room hospital, this is the initial investigations. The anti-HIV test was positive, and CD4 count was around 128, and cryptoantigen was negative. The triple antibody also positive with a RPR result of 1 to 2, and the anti-HCV was positive too. At that time, the CBC result was in normal limit. So he was scheduled for another OPD occasion, but he have developed exceptional dyspnea a month before he was in our hospital, and the nighttime dry cough was also worsening along with his progressive of the rashes. So he was diagnosed with pneumonia and readmitted to that hospital. This is a picture of his eyelid nodules. It's a related to violaceous nodule on the upper and lower eyelid of his eye. Along in it is a conjunctival mass here. He also have a violaceous nodule in his mucosal in the hard palate. Here are the skin regions. It is a multiple brownish to violaceous papules and plaque over his extremities and his trunk. So for the progressions of dyspnea, the X-ray do progress in 2 weeks, which found to be the diffuse gas opacity predominate in right upper and right middle lung zone. So here come the first questions. What is the cause of these patients' rashes and conjunctival masses? A. Bacillary angiomatosis, B. Kaposi sarcoma, C. cutaneous leishmania, D. disseminated dimorphic fungal infection, or can be more of these or other choice. You could vote now. Many audience seem to choose the bacillary angiomatosis.
Oh, it's B. It's
Oh,
Kaposi
sorry.
sarcoma.
It's Kaposi sarcoma, sorry.
Okay.
So,
Okay. Maybe just ask the panelists. Oh, okay.
Yeah, because the lesion is a violation lash and distribute on also more oral mucosal, and also in the skin you can see the arrangement of the rash is along the skin line to elliptical shape, so it's kind of typical of Kaposi sarcoma. It can be differential diagnosis with bacillary angiomatosis, but the lesion is for the BA. The lesion should be like a more nodule and more because it's a tumor of the vessel, so it should be like a nodule and more bloody look like. And for the cutaneous leishmaniasis, so it's not look like cutaneous leishmaniasis because as we know, the vector of the leishmania is a sandfly, so the lesion is usually appear on the skin exposed area, which is sandfly can bite the patient. So, but this patient have lesion generalized all along the body, so it's less likely to be leishmania.
Okay. So any comment?
I think looking at the rash, the characteristic that is mentioned by the other panelists, it is what do you call that? Kaposi sarcoma until we rule out otherwise. It's very characteristic. And in fact, even in Kuala Lumpur, in my center, it's in the Kuala Lumpur where people are educated, they know their risk, but they present late. We actually have a few cases of Kaposi sarcoma, and there was one that looked exactly like that in the conjunctiva of the eyes. But that was further complicated, as in he had jaundice, and that was actually caused by obstruction to the the vessels in the hepatic ducts that was contributed by this mass of Kaposi that is obstructing the biliary tract. Yeah, so that was difficult because when we see the lesion, the mass over there, the first thing that come to mind to determine the diagnosis would be to biopsy the lesion. But in this case of Kaposi, because it is a tumor of the blood vessel, so it is very risky to biopsy that part. I mean, this kind of tumor, especially if there will not be any tamponade to stop if any bleeding occurs. Yeah, so it's and this looks like a disseminated Kaposi, so it's yeah. We need.
Yeah, thank you. So there are two types of manifestation in this case. The first one is the mucocutaneous manifestations, but the other thing is he has dyspnea and dry cough for 1 or 2 months. We should think about this as Kaposi sarcoma that involve lungs, or there's another process that going on in the lung, because we usually see in case HIV infected individual with low CD4, they usually have more than one etiologies that involve in one case. So in my opinion, I think I want to go with the biopsy at the skin lesion to prove for the Kaposi sarcoma, and I will send the investigation for looking for the other pathology at the lung, because it might be Kaposi sarcoma itself, but it might be the other things like tuberculosis or some dimorphic fungi that can explain the symptom of the lung.
Okay, maybe you just vote for the next question, that
So the
Dr.
next,
Opas already touched on for some. Okay.
yes, so let's vote. What is the cause of his respiratory tract symptoms and lung lesion in chest X-ray? Whether it is PCP or Mycobacterium, CMV, or this is Kaposi sarcoma. Oh,
So what?
so
It's a B,
it's a
mycobacterium?
B.
Okay. So let work up. So maybe just work up first, or anyone want to discuss in this point? Otherwise, we just go to the workup. So for this case, it's sarcoma, Kaposi sarcoma. So we just work up what the lung is caused. He's a dyspnea and abnormal chest X-ray. Okay.
So
just work
this
up.
is the workup result from the previous hospital. The hemoculture showed the Salmonella bacteremia, and he was diagnosed as a presumptive of the PCP pneumonia without getting his sputum or bronchoscopy. The treatment was trimethoprim somatic toxazole for the dose of severe PCP with a high-dose penicillin. So 1 month before he came to us, he had treatment with PCP with a high-dose steroid. And after that, the symptom of cough and dyspnea seemed to be a little improved, and he sees the patient sees the physician at the outpatient clinic a week later and started ARV, which is a TLD, and treat the late latent syphilis. After that, he revisited to us due to the syncope episodes after the changing position, and he also have a persistent dry cough, dyspnea on exertion, and generalized edema, as well as a low-grade fever. So physical examination at the emergency room showed that he had a hypotension, marked pale conjunctiva, and in the eye ground exam, the physician saw that this is edema and presumptive of the retinitis of right eye. He also have a generalized lymphadenopathy, generalized edema, and the velocious lash still progress. So the initial workup showed that he had the problem of worsening pancytopenia from the previous blood result 1 month ago, and the severe hypoalbuminemia. So this comes to the third question. What is or are the cause of his newly developed acute pancytopenia? Whether it is a disseminated infection with Mycobacterium or dimorphic fungi, or it caused from the bacterium, or it is a HLH, or it is an inflammatory cytokine syndrome from Kaposi sarcoma, or you can choose for other reason. So we have the equal voting in the cause from the disseminated infections and from the bacterium.
But for the lung, you haven't answered. So what's the cause of abnormal? Is it PCP or?
So it was presumptive to be PCP, but the investigation come later.
Okay. So at this point, who want to start first? Okay.
Well, I was just going to reflect on something that Dr. Opas said earlier, which I think is really important, and it brings to mind is that we see quite a lot of late presenters as well in Sydney, actually, with this kind of, and they often have multiple pathologies going on at the same time. Normally in medicine, we think if one thing's there, it's normally causing all their things, but I think that doesn't hold true when you've got somebody with late-stage HIV. So I think, this obviously, man has crashed in many ways, including with a hemoglobin. So, he could be bleeding from his gut, right? He could have Kaposi's in his gut. He could have MAC in his bone marrow. He could have disseminated TB. He could have, he's Hep C positive, right? He could be cirrhotic. He could have varices that are bleeding in his gut, and it's, so I think he could have any one of these number of syndromes, and I think it's really hard. You've got to start from first principles and work out, is he bleeding? Is it a bone marrow problem? Is it a drug-related problem? It could be many things. So I think it's really important to keep that very broad.
So any more comment?
I think that the symptoms of edema and the other things start after starting ART, right? So it might be the role of iris that occur in these patients, because sometimes if the patient have underlying tumor or underlying opportunistic infection, when you start the treatment, there might be immune reconstitution syndrome. So it might explain the pathology at this moment. But I think that I will stick with the lesion in the lung and send the investigation to look for the pathology at the lung. And I don't think that in the lung there is PCP, because the duration of the illness was too long for PCP. It's like 1 or 2 months. This is not typical for PCP. In HIV-infected individual, PCP usually like a month or 3 weeks, 2 weeks. So the duration of the illness in the lung was too long. It's not compatible with PCP. We should look for the other things like mycobacterial infection or Kaposi that can involve the lung and have some high risk after ART initiations. And also the other things like dimorphic fungi.
Thank you. Elliot, you want to say something?
Yeah, I mean, so I guess one thing I wonder about would be, I agree that this could be iris, but I also wonder as far as if iris would be the explanation for the severity, only because you happen to have given this patient high-dose prednisone as part of the empiric treatment for PCP, and I think, well, I don't think it's 100% guarantee. I think that in theory might be somewhat protective against a severe syndrome of iris, especially because you actually gave the prednisone prior to starting ART, if I understand the timeline correctly. And then I also think, I think this does, to Gail's point, actually the patient already had 2 diseases because of salmonella. So I think that we already had 2, and the patient could have 3 things. So it doesn't have to be even limited. Well, the patient, 2 and maybe 3, something in the lungs, KS probably, and then salmonella, that we know. And the question just is the something in the lungs a 3rd disease or not? And then, so I think that, but I do think that means you have to maybe consider, because of this, because these cases are so complicated, do you want to keep giving empiric treatment, or do you want to, despite the potential risk of biopsy or bronchoscopy or whatever it is, do you want to proceed with the diagnostic studies rather than continuing down the road of empiric therapy? Because in this particular case, it hasn't gotten you very far, and now we're rethinking the PCP, and we've given all these steroids, and so it's just something to be thinking about as you're making your decision. Do I treat empirically, or do I start down some diagnostic pathway here?
Okay, thank you. So just move on.
The first diagnostic test that the patient have been done in hospitalizations is the bone marrow aspirations, which shown that there is a decreased methylation of myeloid series. According to the hematologist, they think it is a granulocytosis, which the copy duct is likely to be bacterium. But we also send them to the blood from the bone marrow to culture for the mycobacterium, which later on show the growth of the mycobacterium avium. The PCR for TB or expert from the bone marrow blood result in negative result, and for the GMS exam, we show no intracellular pathogen or any dimorphic fungi that we suspect. And in the first week, patient was undergo to the bronchoscopy with the bronchoalveolar lavage from the right upper lung zones. We see that the PCR and IFA for PCP is positive after the treatment, and we see also the culture positive for Mycobacterium avium from the BAL analysis, and for the culture, the fungus culture came back to be the Aspergillus fumigatus complex. They was also done the biopsy from the bronchoscope. The transbronchial biopsy showed that there is some of viral infected cell to be suspect, morphology consistent with the CMV, and for the pathology, there is no spindle cells in the pathology panel that they suspect. And the blood test come back with the CMV viremia in degree of 30,000 IU per ml, and we also do the PCR for HHV8, which is positive for cycle ratio of 32, and the HCV viral load is also sky high. But hemoculture for micro F lytic culture still no growth. The skin biopsy at his right inner thigh showed to be the Kaposi sarcoma plaque type. For the hospital course, after we healed the bacterium, and he was treated with transfusion support and GCSF subcutaneous injection. You can see that the platelet and the hemoglobin rise, but still in the lower degree. For suspect of CMV disease of retinitis, pneumonitis, and viremia, he was treated with ganciclovir, both IV and intravitreous route. And here is his vital sign chart. Steroids still be used in these patients because of the CIRSE or critical illness related corticosteroid insufficiency. He have the high-grade fever along his treatment with steroid and ganciclovir. The antibiotic was given for only 2 or 3 days with the ceftriaxone. Then the ARV for TLD is still given all along the course. And for the second week, he tends to have a worsening tachycardia and can have a clinical of gut obstructions. So GI unit was consulted, and this is his EGD result. We can see that there is a oliceous masses in the esophagus and at the fundus of the stomach. And here, the oliceous nodules or mass is along the D1 duodenum, causing the gut obstruction. So it's a brief review here about the AIDS-related epidemic Kaposi sarcoma, which primarily occur in MSM and AHD patients. It can have a wide spectrum of single lesions to disseminate cutaneous disease. So the lesion can be erythematous macule, plaque, or purple-black nodules. Common site that occurred is in the mucosa, midface, and trunk. And it can involve a visceral disease and flare with the iris. For the histology, it is different between the stage of the Kaposi sarcoma, whether it is patch, plaque, or nodular, but all demonstrate the expressions of LANA1, which is the expression of latency associated nuclear antigen. The treatment is to continue the ART and give the chemotherapy in the severe case, defined as the symptomatic visceral disease, such as in these patients, or extensive oral lesions, painful or disturbing tumor associated with facial, genital, or peripheral edema, or progression disease despite the ART. So as the thing to mention here is the immune response for the Kaposi sarcoma in every patient do different, whether it is the inflammatory cytokine syndrome or multicentric Castleman disease, or in this case it is the iris. We can see that the lesions are progressive rapidly after we give him an ARV, and the viral load in his blood is low, as cycle threshold is 32. And about the iris and KS, it seems strange that many iris tend to be respond to steroid, but the steroid and Kaposi sarcoma seem to be the things that may aggravate the iris or have a higher mortality. As you can see, this is a cohort that KS may not respond to steroid that given prior to the diagnosis of KS. Normally, the patients went on the hydrosteroid from PCP pneumonia, and the one that have a steroid have a worsening KS iris and have a higher mortalities. So as you can see in these patients, there are many etiologies for the lung symptoms or his systemic symptoms. He was diagnosed as AIDS with a history of PCP pneumonia and disseminated CMV, Kaposi sarcoma, which have many organ involvement, and iris, disseminated Mycobacterium avium, and HCV infections, and probable IPA. So for the hospital cause, Kaposi sarcoma was targeted first as a systemic chemotherapy, including liposomal doxorubicin was started, and the gut obstruction symptom was improved in weeks. For disseminated MAC, we use azithromycin IV and ciprofloxacin IV along with ethambutol YNJ tube. And for IPA, we also treat the aspergillus because the patient may have to go on the long course of chemotherapy with amphotericin IV. And lastly, we treat the HCV in the OPD clinic. And the ARV was continued all along the way with the TLD, and the virologic was suppressed at 6 months. Here is the result after going through many treatments for years. His chest rate was improved along with his heart size is decreased, and there is new nodules developed in left upper lung zone, which proved to be Kaposi sarcoma later on. So this is the table that we can differentiate diagnosis of the disseminated viral papule, which tends to be the sum of the infectious etiology in AHD patients. As panelists discussed, there is a Bartonellosis that should be in the list of differential diagnosis. And in our country and some part of Asia, maybe India, we have a Leishmania species which can develop the unique skin lesion in AHD patients, just like this. It can be violaceous too, and it can be disseminated at the trunk too. And as the panelists say, the Bartonellosis may be more reddish and more not so patches or large as Kaposi sarcoma. So the point of learning here is multiple opportunistic infection and approaches in individualized AHD patients and AIDS-related epidemic Kaposi sarcoma and KS iris.
Okay, so thank you. So I think the point that you raised yesterday, very important that, so we should try to, so how can we bring the patient for HIV diagnosis or HIV early to prevent advanced HIV, like some kind of this study. So if he were with the small hospital, I think he might die because he cannot, so the hospital cannot have any workup or any medication or specific medication. So any comment from the panelists or the floor? The question and the comment from the floor? Okay, no. So we don't know. So, oh yes, please.
Well, I mean, this is a really bad case, but I'm still going to go back to what I said yesterday. I don't think this case should make us fear starting ART. You know, and just because I think ART, you know, we have to be vigilant and have the patient in the hospital, and as you said, have the patient in a well-resourced hospital. But I worry that when you see a case like this, people are going to come away saying, I don't want to start ART because, and I think we just have to be careful about that because there could be a downside to that. I'm curious about, because you mentioned about the biopsy. In your hospital, will they give chemotherapy without biopsy diagnosis of Kaposi sarcoma?
So we have already done the biopsy in this
No, I know in
case.
this case you did, but empirically, yeah.
In Rama, I think we need biopsy to confirm the diagnosis before we give the systemic chemotherapy.
Yeah, so generally in Malaysia, we do biopsy as well.
Okay.
Just that, you know, perhaps in some difficult cases, it may not be so. Yeah.
And then the only other thing I wanted to ask is I'm curious, because here I made the comment about steroids, and then you present that the steroids were a risk for the Kaposi sarcoma. So anyways, the question I want to ask you is, what was that study, did that study look at whether it's whether the receiving of steroids was a proxy for how sick the patient was, rather than the actual steroids as the risk factor? Were they able to tease that out? They might not have been able to, or does anyone on the panel know? Because I'm actually not familiar.
It's a randomized controlled trial, was it?
Yeah, so I mean, that's the one that I just think, you know, like this patient got steroids because they were sick, right? And so then the question is just being sick, is having the most advanced of advanced HIV disease the risk factor for Kaposi's iris, or is it the actual receipt of the steroids? And maybe they couldn't tease it out. They probably could.
So for me, I would like to add about the chest symptom, because I think that the chest symptom is not classic for PCP, as I mentioned earlier. So when you did the biopsy and you see PCP, it doesn't mean that there's only PCP, because in this case, you see that there are two things in the lung, at least three, I think, PCP, CMV, and Kaposi sarcoma.
And
So
aspergillus as well.
yeah, and so many things. Some of them may be colonization. Some of them might be through pathogen. You need to determine and use the clinical information to judge what is the appropriate test, and use the test conjuncted with clinical manifestation to choose the treatment.
Okay, so thank you.
Let me just say congratulations on the patient's survival to 6 months, okay? Because I mean, I think that suggests that despite everything, all those things you just listed, and the patient was still around for that 6 months viral load, is really a good reflection of the care the patient received. So congratulations.
So thank you very much. So just move on to the next case before we have break. ฮะ break เหรอ
มีสี่เคส
เอาไม่เป็นไร so เอาไป case the next case first.
Okay, so
We still have time until 3 p.m.
So the next case is about STD management. He is a 33 years old male MSM architect living in Bangkok. He have multiple partners with the using of oral PrEP for 5 years with a regular 3-month interval and the HIV tested. And the last unprotected SI was 1 week prior to admissions. He now presents with the anal pain for 4 days. And for 6 days PTA, he noticed the painless and non-itchy rash around his anal area without any systemic symptoms. Fearful disease, he went to the local private clinic and diagnosed with the genital wart, treated with the cryotherapy and antibiotics and painkiller. At that night, he developed the anal pain and fever and requiring the painkillers to relieve. 4 days, fever tend to be higher and the anal pain still persists. He also developed the trypanosmus, and the stool is mucus-like and but stick. So he revisited another clinic, and the test for STD result in the anti-HIV and triple antibody and the HCV is all negative. So the rash was not addressed by that doctors. And 3 days PTA, he had the worsening anal pain, rashes, and fecal incontinence. And 1 day before admissions, he developed new rashes over his forehead and cheek. And here are the picture of the rashes. You can see it here first. It is the perianal area. It's multiple discrete umbilicate papules on the anal sphincter and perianal area. We tend to be cause dirty base ulcer and crusted. And there is different kind of papules in his forehead and his back. And at that time, no superficial lymph node was palpated, and the proctoscope by colorectal surgeon saw that there is severe proctitis. So this comes to the questions, what is or are the causes of his proctitis, whether it is mpox, Neisseria gonorrhea chlamydia trachomatis infections, herpes, or Entamoeba histolytica. Okay, a few things is mpox first and accompanied by the Neisseria gonorrhea chlamydia.
Okay,
Herpes.
so let's see the panel. So this case is Dr. Opa's favor, so maybe just start with you first.
Okay, thank you. Can you go back to the photo? Yeah. So this is umbilicated lesions that are disseminated throughout the body. So I think this is the systemic process that can cause this disease. When we look at the lesions, it's umbilicated lesions that might be viral, some kind of viral like mpox, or this is not vesicle. I don't think that it is herpes simplex or zoster. Or it might be the other things like molluscum contagiosum, but if it's painful, it should be monkeypox or mpox. I think mpox is my first differential diagnosis on the list of differential diagnosis. However, the patient has the other type of symptom. He has severe proctitis. It might be mpox or something else, or in combination, the other thing plus mpox, because we have seen a lot of mpox cases. They have multiple co-infections, because once the patient have STI, they might have the other STI. So this is the rule. So I think that we are so sure that skin lesion is mpox, but for the proctitis, it might be LGV, which is very severe, or herpes simplex infection of the rectal area cause herpes proctitis. So I think I want to send a test for to prove that diagnosis for the other type of infection other than mpox.
Okay, thank you. Yeah, Dr. Ong.
I think mpox would be high up in the list of differential like Prof mentioned, but looking at the type of lesion, the type of rash that we have here, raised, centrally umbilicated, we need to also rule out like systemic or disseminated histoplasmosis, systemic fungal infection. So blood for fungal culture, biopsy, of course, to look for mpox and also for fungal culture, I think will be very helpful in this case.
Lee Sivaporn, you have any comment?
So I think about mpox as Dr. Opat says, and also herpes. But for the disseminated histoplasmosis, because his anti-HIV is negative, right?
Yes.
Yeah. So
He's on PrEP.
he on PrEP. So
MSM on PrEP.
yeah, he on PrEP. So and he's HIV anti-HIV negative. So in this minute histo in non-HIV, we can see that, but it's less likely to be histo for my opinion.
Ire, do you have comment? So
Yeah,
have
I
you seen
think
that case?
I
think several cases in US.
I think in the U.S. at least, the vast majority of the severe cases of Mpox among the MSM population were people who had HIV. So I'm not saying you can't get a severe manifestation of Mpox like this, including proctitis, without HIV, but it just seemed like we just weren't seeing that. So that's the thing that I think, makes me also pause a little bit regarding Mpox. The other interesting thing is that pain, in my experience at least, pain was the most common early manifestation of Mpox, and so this patient was actually pain-free when the lesions came on, and I can't help but wonder what, if any, what the role of the cryotherapy was in all this. Obviously, we know it was the wrong thing to do, but did it actually make things worse? I don't know. So I agree. The negative HIV is throwing me a little bit into a more broader possibilities.
Gail, you have anything to say?
Only that in Sydney we see lots of patients like this with severe proctitis and Mpox with co-infection often at the same time, and a lot of them are HIV negative virtually. So I would think this is Mpox with possibly other coexistent STIs, including syphilis, gonorrhea, LGV, etc.
Okay, thank you. Okay, Napon, maybe just progress.
Yes, for the investigations, the PCR for Mpox virus at the perianal papules and rectal swab showed it to be positive, and the swab for multiplex PCR for herpes positive for herpes simplex virus 1, along with the STI panels is positive for Mycoplasma hominis and Ureaplasma urolyticum. For Mpox clade, it is clade 2B, which is the pandemic clade now, and it is lineage C1 from the whole genome sequencing. And others serologic workup show that anti-HCV is negative, and the RPR result came back 1 to 64. And initial lab, he has mild elevated in SGPT. So the treatment was tecovirimat and acyclovir and pain control. And he was hospitalized due to the perianal area and the cryotherapy wound, with causing him to have a severe pain and have to look at the lesions periodically because afraid of the strictures. So after the tecovirimat for 7 days, his symptom around the perianal area lesions is getting better, but in the 4th day or 6th day of admissions, his lab showed that mild to moderate transaminitis, which he have no symptom at all, no epigastric pain, no nausea, vomiting. So it comes to the second questions: what are the possible causes of hepatitis in these patients? Whether it is Mpox, it is tecovirimat, or it is secondary syphilis or other choice. Many seem to think it is from the tecovirimat and secondary syphilis.
Okay. So Gail, can you, do you want to say, something about this case?
Well, yeah, actually, I was interested in people's thoughts about tecovirimat because, a while ago it was very our access was very limited, right? So we reserved it for the really serious cases that we were worried about in hospital with organ involvement and so on. And it's since become easier to get hold of, but obviously the results of the studies really suggest that it probably doesn't do anything anyway. So I was interested in your kind of everybody's practice in terms of tecovirimat now, and whether they think it added anything in this patient's case, or probably maybe just gave him a bit of liver derangement along with the other things that could have. I'm not that worried about his liver, by the way. I'm very comfortable with liver
Okay,
tests.
so just respond to that question first. What you want to respond to that? The question about the tecovirimat.
What do you mean? You mean the response?
No, I mean the practical.
Okay.
Whether we prescribe tecovirimat to
Well,
in Thailand.
in the past year, we had the guideline and we followed the CDC guideline for the recommendation for giving tecovirimat to mpox patients. We usually give to people with high risk of disease progression, like immunocompromised host, pregnant women, or kids, and we recommend to give TPOXX or tecovirimat to people who have some specific anatomical involvement like keratitis or at the orifice that can cause future stricture. So this is the recommendation. But in this case, I think he fit for the recommendation for TPOXX administration. However, I think many of you may have heard that the trial for tecovirimat has stopped already because of there is no efficacy in both clade 1B and clade 2B. So now I think we don't have the options now, just symptomatic treatment and take care for the superimposed infections or co-infections and pain control, which is a key. In this case, I think that the elevation of liver enzyme might be the drugs, and because it has temporal relationship with drug administration, and for the syphilis, hepatitis, I think that it is unlikely to be syphilitic hepatitis because in patients with syphilis and they have hepatitis, the hallmark is elevated alkali phosphatase. So this is not fit for syphilitic hepatitis. So I think that it might be tecovirimat.
Yes, Lee, you want to say something?
So I would like to add on, Dr. Opat just mentioned the study that you mentioned the STORM trial, right? So they just released the result that tecovirimat is not shorten the duration of the rash resolution or pain. So they stopped earlier by the last year.
Yeah, so actually, this case, he was in the STOMP trial. He was in the STOMP trial. And I think for the STOMP trial, so they have less severe case. So it's difficult to say whether for very severe case that the TPOXX have effect or not. But anyway, that the study was premature termination. And any comment on that? So now we talk about so the patient has mpox and with the proctitis, and also have the abnormal ALT after the treatment. So what we're gonna do with the abnormal ALT?
Just again, sorry. Do we have to screen all of the hepatitis panel? Did you?
So for this case, yes, the anti-hepatitis C was negative. Hepatitis B, he already has immune to that, and Hep A, Hep E, IgM is all negative.
Just to comment on the liver function test, if you go back, so his bilirubin's normal, right? I don't use your units, so that's a normal bilirubin or
I think it's normal.
It's normal.
is that normal for you? Yeah, because DILI, drug-induced liver injury, if it is drug-induced as opposed to the syphilis, as I said, I'm not that worried. It looks like it's almost turned the corner anyway. But it's when your bilirubin rises in conjunction with your liver function tests that you really start to worry about significant morbidity from raised transaminitis in terms of DILI. So I would be watching his bilirubin carefully and watching the trajectory of his liver function, but it looks like it's almost turning the corner already.
Another possibility is acute hepatitis C.
Yes.
Because his last sexual intercourse is 1 week, right? So, and he developed mpox, and he may get hepatitis C at that time. So anti-HCV may be still negative. So we should send for HCV viral load.
Agree, because I think that for the cause of hepatitis might be the drugs or the other things like viral hepatitis. You should remember that when the patient exposed to the virus, it takes time for the antibody response to be seen by testing. If the patient is in acute phase, the antibody might be negative. So we need another test to prove. So in this case, we need to differentiate between drugs-induced liver injury or the viral hepatitis. We have seen a lot of cases. The patient usually presented with syphilis and then later hepatitis C co-infection, but at the time of syphilis diagnosis, the anti-HCV was negative because the window period of hepatitis C is so long. When you see the patient with syphilis, the anti-HCV may be negative. You should follow up later to see whether any positivity in serology of hepatitis.
Thank you very much. So this young MSM on PrEP, right? And also have the mpox, have multiple STI. And as Dr. Opas was saying about the syphilis and hepatitis C, so I think we should always think about acute hepatitis C or acute hepatitis A in MSM who presented with abnormal ALT. But the Hep A, they usually have jaundice. So, but for Hep C, majority they are asymptomatic hepatitis. And for antibody, so it will turn positive after 6 to 8 weeks after infection. So during the 8 weeks or 2 months, it might be negative. So you have to check for hepatitis C. So we have seen this very common. So why at the HIV-NAT clinic? So we usually say that if patient, if MSM and have syphilis, we have to look for hepatitis C. And yes, we have seen a lot of acute hepatitis C in that population. It's like they come together with the STI. So acute hepatitis C is also one of common STI among MSM, and especially if their partner if they are HIV with hepatitis C. So with that population, they tend to have high hepatitis C RNA and in the blood and in the semen. If you look at some study, you can see that. So for the HIV Hep C co-infection, they have high hepatitis C. So almost 40 to 50% have high hepatitis C in their semen, compared to just only 20% for Hep C without HIV. So why they have such a high risk of Hep C transmission? So in this case, so we think about the acute hepatitis C, very high viral load in this case. Yeah.
And Angela's probably laughing because I actually did a lot of the work on acute hepatitis C in HIV-positive men, and I didn't mention it. And I have to say, I haven't seen it because in Australia, we virtually eliminated hepatitis C from our population. We haven't seen an acute hepatitis C like we used to see, like you described, and like you're still seeing here for now several years, actually. You know, we see it obviously occasionally, but it just has dropped right down our differential list because we've eliminated hepatitis C in our population.
Yeah, but because you just test and treat for all,
Yeah.
but for our patients.
Oh yeah, of course.
So after they are treated for hepatitis C, and then they have re-infection again because
you haven't got it high enough up in the population.
Yeah, so you have high outbreak in that population. And also we can show that it's a genotype C. It means that we get it from, so for MSM, mainly genotype C compared to like a drug user population is genotype 3. So we might get this abroad from other like a
Not from Australia.
Oh, maybe in the past, and then it circulated in Thailand. So any of your patient or your friend or anyone come to Bangkok and have and practice as MSM, you have to think about this situation as well. Yeah. So we try to have like we call micro elimination of Hep C, but it's not meet
No.
that target
I
yet.
think Australia is very unusual because we're so isolated and we've got a small population, a relatively small population. So you get some incoming from obviously overseas, but enough. And our policy is such that they get tested very quickly, it gets treated very quickly, so it never is taken off again. So I think we're one of the few countries where we've been able to do it, and it's because we have the sort of, we're kind of quite separate from. So in Europe, for example, it's very difficult because people are just moving around all the time.
Okay, thank you. So we're gonna follow your stop C in prison. So, so just start have C in prison for everyone. Okay.
So as for the progressions, his perianal lesions resolved in 7 days. And for our body lesions, the forehead and body lesions resolved in 2 weeks. For hepatitis C virus infections, his enzyme returned to baseline after 2 weeks, and the SVR was achieved after the software regimen. For HIV follow-up, his anti-HIV 3 months later still have negative results, and the patients resumed the oral PrEP as the same regimen. For secondary syphilis, he was treated with benzodiazepine G for 2.4 million unit doses. And for mycoplasma and uroplasma infections, he was treated with doxycycline for 7 days. And he also was treated for herpes simplex virus in admissions. So I would like to touch about the mpox a little bit here. So this diagram shows its life cycles for the cell entry, and the virus only live in the cytosol, which they have their own enzyme for replications. So the gap for treatment here is we don't have any options for the treatment. First, we have to inhibit the cell endocytosis by monoclonal antibody or vaccinia immunoglobulin. Secondly, we have the inhibition of DNA replications by cidofovir or brincidofovir. And thirdly, we can inhibit the exocytosis by tecovirimat. But all of them seems like to have no current effectiveness in treatment of mpox in clinical studies. As panelists said about the STORM study with prelim result shown as both the tecovirimat did not reduce the time to lesion resolutions and the pain among adults with mild to moderate grade 2 mpox. Another study is PALM 007 in Congo, which mainly involved in children and grade 1 mpox. The tecovirimat result is not good as well. There is no significant difference in time to lesion resolutions, as well as the mpox PCR resolution as 14 days. And the PK study showed no relationship between concentrations and efficacy. We still have an ongoing trial. It is Unity trial, Epoxy trial, Platinum Can trial. And interestingly, we have the clinical study about the brincidofovir efficacy in grade 1 mpox called MOSA trial. So the problem about mpox trial endpoint limitation is the clinical resolution of skin and mucosal lesions. There may be some problem of measurement of the mucosal lesions, such as these proctitis patients, whether it is reliability or not, or it is clinical meaningful or not. And secondly, about the significant event from the mpox, whether it is death, hospitalizations, or secondary bacterial infections, all of them is a rare event. So, and it only developed in high-risk populations. So we need higher number of participants for this to prove whether the treatment that we have can work or not. And thirdly, for the virologic outcome, the quantitative PCR resolution is not correlate with the clinical outcome. So we don't know that yet. So for now, we need more data about the efficacy of another regimen, such as the benzidofovir or combination of benzidofovir and tecovirimat, or use of monoclonal antibodies. So the point of learning here is think of STDs, think of multiple co-infections, and clinical trials are still needed to evaluate the efficacy of alternative treatment of severe mpox or in immunocompromised setting. And the last thing is acute HCV infections should be included in the differential diagnosis of acute hepatitis in patients who is at risk.
Okay, so thank you very much. So any comment from the panelists again?
I have the question for you, because the patient is having acute hepatitis C. Should we treat or should we wait? Because I had heard that some of individuals, they have spontaneous serial conversions. You don't have to give antiviral therapy for all acute HIV. Is this correct? Acute hepatitis C.
Just refer to Gail. She is a hepatitis C.
So we did a lot of work on this, and we ran I ran the big randomized trial in acute hepatitis C. But firstly, showing that it's very safe to treat in acute hepatitis C. And what we do know is, yes, you can wait, and you might get 20%, probably less in HIV, who might spontaneously clear. The problem is if you wait, you'll lose some people. And from a population sort of clearance perspective, you're better off to treat. So I think the field has moved from that kind of idea that let's wait, because with interferon, you didn't want to put people through interferon if they didn't need it, so you might as well wait. But these drugs are so safe, they're so easy to take, they're so cheap now, mainly most places, easy to get hold of. Just treat, and the sooner you treat, the sooner you bring population viremia down.
Yeah, thank you, Gail. So I absolutely agree with you, because not just the patient lost to follow up, but they can spread the Hep C to other people, because during the acute, they have such a high viral load. And for Thailand, just for Thailand, so the treatment of acute hepatitis C has been approved from the national program. And also for the software, now it's not the JAW2 drug anymore. So it's you can use as a other medication used by GI or ID experts. So we try to cut down almost the barrier to treat hepatitis C. Yeah.
So I have another question regarding to the Hep C treatment in Thailand. So for clinician here, so how many episodes of hepatitis C that we can have a free software for the patient if they already complete the first episode and they got another second episode, so they can reimburse for the national program or not?
So what do you want to say, Gail?
Well, I can't answer, obviously, what you pay for in Thailand, but what I can say is it's really important to keep treating, because those are the people who are most likely to be transmitting, the high-risk people who keep getting infected. So you have to keep treating them. You have to keep treating their reinfections.
Yes, for our guideline also say something like that the second course might be, so you can extend the duration, or you can add ribavirin to just only for 12 weeks. So we allow, I think, for another additional one course of the treatment. And so why it's very important that all their partner should check for hepatitis C and should be treated. Otherwise, it will be circulating among that group again.
So when we were looking in Australia, from the time we brought DAAs in, we had widespread DAA. You could use it as many times as you wanted. And so it took a few years, and some people we treated 4 or 5, even a few people even more than that. But as everybody got treated, then even though their risk behavior continued, then they weren't getting infected again because nobody else had hepatitis C. So it's like treating the population, and some people have to keep treating until you've got it, but that's in a closed environment in some ways.
So your question, actually, for now, the software is not JAW 2. So it doesn't limit the time of treatment. So you can treat as whatever needed.
So I would like to ask the expert about the prevention, because I don't like to keep on treating multiple episodes of reinfections. Any improvement or advance on the hepatitis C prevention for now?
Do you mean vaccine?
The vaccine or PrEP or post-exposure prophylaxis?
Well, the thing is with PrEP, I mean, there's no point really, even in PrEP or post-exposure prophylaxis, when you do have a very good short course treatment that is going to cure everybody, because then actually, to do PrEP, for example, it's very different from HIV. You'd be having to give it to lots of people for very little benefit. You may as well have a program where you're testing regularly, you just jump on the infection as soon as they get it, rather than try and give everybody PrEP to try and prevent it. Vaccination would be different. I mean, if we had hepatitis C vaccination, I think that would still be a game changer, but no further to that. And the other thing about prevention in terms of preventing behavior changes, it's actually really difficult to cause behavior change. I think we know that, so we can talk about it, we can talk about education and so on, and whether it's drug use or MSM sort of exposure, but we know that doesn't change. So our policy has just been to test, and keep treating when...
Yeah, so I think we should follow Australia. So, like they test so many people and treat so many people, and then they can ending hepatitis C. Yeah,
I was going to ask you, and among the people who are hepatitis C antibody positives and have been treated, how often are you doing HCV viral loads as a screening test for them?
So it depends. So in our MSN, certainly on our HIV positive population, we say annually, and then also if they've been at risk. So, we have gene experts around everywhere, particularly in our drop-in centres, in our drop-in centres. People can get tested whenever they feel that they've been exposed. And then apart from that, it's about risk behaviour. So if you had somebody who was actively injecting, for example, and that's where so most of our hep C at the moment is in prisons, actually. That's the only place we haven't been able to really eliminate it, but in prisons and also in people who inject regularly. So in those people, they can have, 3 to 6 monthly RNAs done. But in our HIV positive population, we were doing annual testing. I think a lot of people stopped doing that because there's no hep C in our HIV positive population any longer, actually. But
yeah, so thank you very much. So I think for nowadays, treatment of hep C in HIV is easier because we use integrase inhibitor. See, in the past, we use efavirenz. We have to switch efavirenz before using software, but now it's easier. So any comment from the floor before? No, right? Okay, so when we have a coffee break, so please come back on time, 3:30, right? 3:30, and we have a very interesting case waiting for you for the last case. So just please join us for the last case after coffee break. So thank you very much. Just enjoy your break now. Bye.
So hope you all enjoy your break. So we will start the last case soon.
Okay, so maybe. Okay, so we would like to finish on time or before time. So maybe we can start. So welcome back, everyone. So we can have the fourth case.
Yes, so for the fourth case, it is in the team of HIV with TB. He is a 31-year-old Thai male. He is a soldier living in Bangkok, and he is an MSM and alcoholism. He was first diagnosed HIV and HPV co-infections 2 weeks prior to admissions with a CD4 count around 21 cells per millimeters. And he also have a problem with acute active pulmonary tuberculosis, which diagnosed by the positive sputum expert alta without rifampicin resistant and a positive urine lab test. He was started with a HRZE standard regimen for 2 weeks. He now presents with generalized petechia for 3 days. His baseline CBC before starting TB drugs, as shown, mild thrombocytopenia from the beginning. This is his chest X-ray before starting the TB drugs. You can see that there is a generalized reticulonodular opacity over his chest film. This is his skin petechia from this admission. You can see the petechia generalized in the blood pressure measuring area and his chest. Also in his mouth, he also have a wet purpura as well. So the problem list is the generalized petechia and wet purpura for 3 days in advanced HIV disease with pulmonary TB, who started treatment with HRZE for 2 weeks, and he have a hepatitis B co-infections. So the CBC in this admission shows severe thrombocytopenia with mild anemia and the white count is in normal range. The blood smear show no hemolysis blood pictures, no schistocyte, no blood cell, and the coagulogram was normal, along with the fibrinogen as well. So this comes to the questions. What is the cause of acute severe thrombocytopenia in this case? Whether it is TMA or thrombotic microangiopathies or drug-induced thrombocytopenia or HIV-related thrombocytopenia, or you can choose other choice. So the equally answer is drug-induced thrombocytopenia and HIV-related thrombocytopenia.
Okay, so let's have the comment from panelists. Okay, Siva.
So for this patient's baseline, he already has thrombocytopenia, which is can caused by HIV-related thrombocytopenia, and after start HRZE for 2 weeks, he developed severe thrombocytopenia, which can be from rifampicin-induced thrombocytopenia. So I would my answer is B, and also together with C.
Mm-hmm. Yes. Any comment? Same.
When I first looked at the lesions, they were petechiae over the body. Before looking at the laboratory complete blood count, we should think about the thrombocytopenia from HIV itself or drug-induced thrombocytopenia or any kind of drug-induced vasculitis, because you can see the small purpura at the leg area as well. So it might be drug-induced small vessel vasculitis, but later the CBC or complete blood count confirmed that the patient has ongoing or declining level of platelet. It should be drug-induced, especially rifampicin.
So, Iris, you want to say something?
I was just gonna. Sorry. The HIV. Let's see. The meds. The HRZ and what else? Any other meds?
No.
HIV with TB. So advanced HIV, low CD4 cell count,
We have
and
not
has
start.
PUVI TB.
Okay, and so it was all within 2 weeks.
Yeah.
I'm just, okay, because I was just
Not-
going to
not-
say
not
that
started ART,
not enough
but-
time for ART, for HIV-induced thrombocytopenia to respond to the ART. So yeah, I don't, that's what I just wanted to clarify. Thanks.
I guess we don't know, again, how advanced his liver disease is, because he's alcoholic and he's got Hep B, right, as well as HIV, so maybe he's got a big spleen as well, background cirrhosis, and then something on top, so maybe that's part of it as well.
Okay, yeah, thank you. So, yeah.
So before we answer the questions, let me ask you a second question. At that time, all the differential diagnosis need approved. What would you management these patients? Whether you give him IVIG or prednisolone or platelet transfusions, or at that time you discontinue the anti-TB medications, you can choose more than this, one choice. So the main answer is give him a prednisolone. The second answer is platelet transfusions. And the third is more than one choice.
So I think it's, maybe just listen to the panel, because I think it's based on what we think, and then for specific treatment later on. Yeah.
So if we think about the rifampicin-induced thrombocytopenia, so the first thing that we should do is stop rifampicin and maybe continue other drugs. And because the platelet is down to 10,000, right? So it's a risk of spontaneous bleeding. So we worry about interstitial bleeding. So we need to have platelet transfusions. And another thing is, I will add more than this choice, start ART as soon as possible.
So any comment other than this? Yeah.
Yeah, at the same time, I would also want to look at how the liver is looking like, whether it's cirrhotic, and also send for the like Hep B viral load at this point in time, and see if there's any benefit of like the antiviral at this point in time. And yes, stop the rifampicin. Would you substitute the rifampicin for another agent such as levofloxacin? Yeah, because we don't want to put them without rifampicin, one of the main backbone of TB treatment. Yeah, and then we monitor the platelets along the way and see whether we need to do anything else or not.
Okay.
So I don't know what's going to happen in this case, but I guess one question I would have is that if you change the anti-TB meds and you start ART, which is I think what you were saying, and I would agree, I definitely agree with starting ART, but I think the question is then if the platelets improve with that intervention. Unfortunately, you might be stuck with sort of saying we can never give this patient rifampicin, even if that's something you want to do in the future.
Yes, because if you diagnose with rifampicin-induced thrombocytopenia, is this contraindication to re-challenge the rifampicins or to use?
Yeah, but what I'm saying is you also mentioned it could be HIV. Do you think it could be only HIV, or do you think it's going to be a combination at minimum?
I think he has HIV-induced thrombocytopenia at the baseline and on top with the rifampicin.
So his baseline liver function test showed normal albumin level, and from physical examinations, there is no chronic liver stigmata, and there is no splenic enlargement and liver enlargement. For this patient, he was admitted and he was given the platelet transfusions and 1 dose of IVIG for suspect drug-induced thrombocytopenia. And his platelet count increased to 100,000 3 weeks later, given the IVIG and stopped the rifampicin. the regimen was changed to SZEL, which we substitute the rifampicin with levofloxacin and show a good response. But culture later confirmed it to be drug-sensitive TB. As for the HIV infections, the ARV was initiated later when the thrombocytopenia resolved. So it's a question for the panelists. What anti-TB regimen will you use and avoiding the rifampicin? And would you use the regimen with rifampicin?
Can you go back a little bit? So I would like to comment on this because if we think about rifampicin-induced thrombocytopenia, it might be immune-mediated mechanisms. So if you encounter the patient with declining of the level of platelet to critical level, there are two choices. The first thing is platelet transfusion, and the other thing is to convert abnormal immune mechanism. It could be either steroid or IVIG, but in this case, the patient is having hepatitis B co-infection, so I think that penicillin might not be a good choice, and I agree that we should offer IVIG in this case. So for the anti-tuberculotic drugs, if I don't have any chance to use rifampicin, I'm going to replace rifampicin with fluoroquinolone like this, levofloxacin, and that's all, because we have only options that can be used. We know that levofloxacin can replace rifampicin just in case you have contraindication for rifampicin. But for rifampicin, I don't have the experience on that, so I cannot make any comment.
So if we think about rifampicin induced thrombocytopenia, so it's the same class, rifamycin. So I think rifampicin is also contraindication for this patient.
I think one thing I would wonder about is the IVIG. The response to the IVIG is a non-specific response. I mean, even HIV-induced thrombocytopenia can respond to IVIG. It's going to be temporary, but so I guess I'm wondering if we're giving the transfusion, why we also gave IVIG, why we didn't start ART. Maybe you want to explain some of those decisions, just because the IVIG is going to be temporary, and the response is going to be temporary, and if it's HIV induced, in theory the platelets are going to go back down again until you start ART.
So I think the primary physicians want to prove the immune process first, whether it is converted with the IVIG only, or as you said, it is non-specific response from the IVIG. But at that time, I think when adding new drugs, they may just confuse a little more whether there is a change in platelet count after we start the ARV. Is it related to the IVIG or only the ARV itself? So at the same time, they do start levofloxacin as well. So they might think not to get many confounders, I think, for the primary physicians at that time.
Yeah, I agree, and I understand that sentiment. But I do think there's ways you can sort of play out the different scenarios, like I just did, where I said, okay, if this happens, are you never going to give this person a rifampin-containing drug? And the answer was yes, even though you can't say 100% it was from the rifampin. And so I do think that there would have been a way to start the ART. I think there would have been a way to start the ART, especially because that regimen is not a regimen that is commonly associated with thrombocytopenia on its own. So I do think there would have been a way to start the ARVs with the idea that, because if this is primarily HIV-induced thrombocytopenia, you might find yourself giving another transfusion, and you'd want to avoid that too. So I do think if you think things through, I understand what you're saying, because you didn't want to accuse a drug of being the cause if you didn't have to, but I think we've already decided that you're gonna say it's rifampicin, even if it turns out that's actually not true. And so I think you could have just moved forward, again, given what I do believe that the benefit, in this case, I think there's a risk to antiretroviral therapy, but I think the benefit of antiretroviral therapy outweighs the risk, in my view anyways.
So how about if after starting ART and then platelet declining again to 10,000?
So if that, I've seen that happen. I mean, I've definitely seen platelet counts remain, like a patient get IVIG, get antiretroviral therapy, and then the platelet count drops again because, at least in my experience with HIV-induced thrombocytopenia, the response to antiretroviral therapy can be all over the place. It's not immediate necessarily. So if that happens, I would just, you might have to give IVIG again, but I think at least get the virus suppressed and everything. I think hopefully time to exposure will resolve that. But I haven't had it happen lately, but I've certainly had patients undergo splenectomies under those circumstances, if despite control of the virus, they continue to have thrombocytopenia.
Okay. So, any comment? Okay. Yeah,
So
let's go.
for these patients, after follow-up for 6 months, he quit drinking and take a ARV regularly. His platelet raised to 150,000. So I think I would like to touch here about antituberculosis-induced thrombocytopenia. So it's mainly caused by rifampicin-dependent antibody targeted the glycoprotein 1B1X or 2B3A, which is a type 3 hypersensitivities. Other drugs that may cause this immune response is quinine or sulfonamide and NSAIDs. For drug-induced thrombocytopenia, it can be severe because the platelet count drops rapidly and it causing decompensation and bleeding. For the timing of the exposure for rifampicin and develop the thrombocytopenia is about 4 to 14 days, and the platelet count is around 5,000 to 17,000. For the risk, some people may have exposed to rifamycin medications. It may shorten the time for thrombocytopenia to be occurred by immune process. And for diagnosis, it used a timeline in clinical, no standard, gold standard for diagnosis these conditions. And for the management, they often withdrew the culprit drug, which is rifampicin, and its uncertain benefit of the corticosteroids or IVG or plasma exchange. So what regimen will we use for the drug-sensitive TB that can be used in the patients who can't tolerate rifampicin? For latest guideline, we can use the BPAL-based regimen in the patients who can't tolerate to rifampicin. And in the TRUNCATE trial, we can use the beticulin linezolid-based regimen along with HZE for the treatment of drug-sensitive TB as well. And if it's old school, you can use the substitution of quinolone or chlorpheniramine, amikacin, PAS, cycloserine, isoniazid, or linezolid beticul. So what about the shorter regimen, the rifampicin moxiflox regimen? Could it be used in these patients? It's the same rifamycin group. There is no evidence of substitute the case of drug-induced thrombocytopenia from rifampicin with the rifampicin. But there's still many reports about the rifampicin-induced immune-mediated hemolysis and renal failure, which is the class 3 hypersensitivity too. So there are some cases that the rifampicin group might have to be in the regimen. In the past, they substitute the rifampicin with rifabutin, but in one case, the recurrence of some thrombocytopenia is so severe and causing the bleeding. So the learning point here is clinicians should recognize that rifampicin can cause acute and severe thrombocytopenia while the immune process and its event can occur in individual without the prior exposure to this drug. And the alternative regimen for drug-sensitive TB.
Okay. So thank you, Napon. So I just would like to ask the panel about tuberculosis preventive therapy, because many have like a debated whether it should be or not. No, just go to the slide. So just these slides just show that when happened with the TB, HIV, it's like a very challenging cases with the diagnosis, HIV for advanced HIV, the pill burden, the IRS, and also the side effect with this case. And also in terms of the diagnosis, especially very advanced case. So it's about 8 to 30% of the positive sputum culture can present with normal chest X-ray. And for the chest X-ray, it can be any abnormal or atypical presentation. And the most important is that the disseminated disease from the autopsy. So they found that almost 90% has disseminated TB to multiple organs. And another thing is that for the patient with prolonged fever or have symptoms, so at the autopsy, almost 50% of them had tuberculosis, was diagnosed at the time of death without starting any TB. So I think TB is very important. Every time if the patient come to clinic, just ask about TB, and TB, whether they have it or not, or whether they exposed to TB at home or TB at the office. So we have to think about whether they should start TPT for close contact or not. And so just the next slide, please. So another important and the 2023 UN high-level meeting target for WHO approved rapid diagnostic test almost 100% in the next 2 years. But for Thailand, it's just about 60%. But I don't know for other countries that use rapid diagnostic test. So the rapid diagnostic test, for example, the Gene Expert machine or Expert Ultra, and another new machine. Who know about this machine? Or any country use this machine? Yeah, very good. So because you come from India, right? Because it's produced, it's made from India. so this TrueNAT is a TrueNAT MTB Plus. So actually it's the same with the Gene Expert, but it's better in terms of it's portable, handheld portable, and can carry to any place, and it can tolerate to high temperature up to 40 Celsius, rather than just less than 30 Celsius for a Gene Expert machine. And so it can be used without plug-in for 8 hours. So that might be easier for like a remote clinic for the disease. And it's not just for TB. So they can do for like a Gail said that they use Gene Experts for hepatitis C. This also the same with Gene Expert machine. But I think maybe it's cheaper than Gene Expert. So and WHO also endorse. You can use or you can choose any molecular WHO rapid test. So for this region, so we are still a home of TB. So we should encourage our staff to use molecular WHO diagnosis. And another thing is point of care test, urine LF lamp. So this is not used as a confirming, just assist for the rapid diagnosis, but you need to do the rapid molecular diagnosis anyway. And also this WHO also recommend for advanced HIV cases. So I just would like to get comment on this. Maybe start with Elliot, because you talk about the advanced HIV and you work for PEPFAR as well to improve this, whether you can provide like a true net to many places that need it. with your funding.
I have to check my bank account, but yeah.
So let me just start by mentioning urine lamb in the light of what I said yesterday, because I think a lot of us pay attention to the pool sensitivity data that you see on that table, but let's also look at the pool specificity data, okay? So in other words, even though, because I think the reality is, as much as we'd like this not to be the reality is that we have a lot of scenarios where CD4 count is unknown, okay? So in the case of a CD4 count unknown, I would err on the side of doing a urine lamb, knowing that if the urine lamb is positive, I don't have a false positive, okay? But I'm not dealing with a false positive, but also recognizing that if the urine lamb is negative, I don't get to just say I've ruled out TB. Okay, so that's one thing I want to stress on the urine lamb. I don't know that that's the way WHO approaches this, to be honest, but I think it is the way we should be approaching it. Just recognizing that it is a pretty specific test, and I think that's the nice thing about it. So and then I think the other question that comes up, which maybe you started to, and then you went down a slightly different path than I expected, is that if we're going to have a policy of TPT, of TPT, and let's say it's based on, like I was saying earlier today, it's based on risk rather than on something like a skin test or a diagnostic test for TB, for latent TB infection, then I think the question that we should be asking ourselves is, what do we need to do to rule out active TB before we start TPT? And how far do we need to go to rule out active TB? Do we need to do all those tests to rule out active TB, for example? Do we need to do a chest x-ray? Do we need to just do a symptom screen? And I think we have to, and I don't think there's a clear answer in terms of the risk benefit. The risk of withholding antiretroviral therapy and TB and TPT while we're waiting to figure out whether the person has active TB, I think there is a risk to that. Some may think there's a benefit to that too, which I can understand. But I think there's a risk to that we need to recognize. So balancing the risk of when do you stop, going down a lot of rabbit holes looking for TB and just put the person on TPT, recognizing that you might be putting a person on TPT who has active TB. I can't guarantee that you won't be doing that. But what happens? You might get resistant TB. It's now easier to treat resistant TB than it used to be, so maybe we have that advantage now. So I just think, risk benefit, you have to sort of take a public health approach and at some point recognize that you can't be, don't, like I said earlier, don't let perfect get in the way of good, of what the right thing to do is, and come up with a policy. And I think each country needs their own individual approach, because so far, WHO doesn't seem to be recommending one approach. So so I don't know enough about the individual tests to sort of say what that is, but I think that, screening, chest x-ray, maybe you can do a urine lamb, especially if you know the CD4 is low, or even when the CD4 is unknown, and then at some point do TPT. The other thing I was just going to say about TPT too is that it's interesting to know what you said on the slide about exposure to rifampin being a risk factor for rifampin-induced thrombocytopenia? Because now I think the question is, we might start using a lot more rifampin-based TPT. And so if we use a lot more rifampin-based TPT, are we going to eventually see more rifampin-induced thrombocytopenia? I don't know what the answer to that is, but it's an interesting thought experiment because we should start seeing more shorter courses that are rifampin-based for TPT.
Okay. Any comment?
I think it depends.
First comment on the rapid test first.
Yeah, I think definitely it's going to be very useful as a screening tool, especially it has very high specificity and reasonably good enough sensitivity in some of them. Yeah, because especially in countries in Southeast Asia where most of us belong to this endemic region for tuberculosis. So it's definitely very helpful, especially they come with symptoms and it's not very clear, sputum is negative. So all these gene expert and the TrueNAT that looks at the gene, it has very high sensitivity and specificity. It's going to be very helpful for us as clinicians.
Okay.
Right. Coming to TPT, I mean, I believe, depending on where we come from, in this endemic region, most of us would have been exposed at one time or another to TB. So it is thought that the TB is inside most of us. So when they have HIV, so when they weigh the risk versus the benefit, I think we follow the WHO symptom screening if they do not belong to suspicious of having TB. So the benefit of starting this TPT is generally very much higher, especially if they come early in their course of HIV when the CD4 is still high. Yeah. Mm-hmm. So that's what we practice in Malaysia. I believe that is so as well in Thailand.
So let's listen to.
So
Rama
I would like to
today.
I would like to comment on regarding the LAM test that you just mentioned. The first thing is WHO do recommend to test to use the urine LAM for screening for TB in people in HIV who have CD4. It is divided between IPD and OPD, outpatient and inpatient. Inpatient with CD4 less than 200 and less than 100 in outpatient for TB screening. And as you say, the sensitivity is not that good because the allele LAM that we currently use is sensitivity is about 50 to 60%. So it's negative. It's not rule out TB. Mm-hmm. So
yeah. So, but if it's positive, yes,
Yeah.
It has a false positive with a rapid growing mycobacteria. But if the patient severe or have symptom, so the WHO recommend to treat TB first and then follow up with the gene spurt or the culture later. So just go to the next slide. Can we have the next slide? So not before this. So this, I think so many of you recommend to treat TB early as I think similarly to all the guideline, including Thailand guideline. Just mentioning that, so the patient should tolerate to TB drug first before starting ART. So just go to the next slide. So just this, I just like to ask you about so the new guideline from the European guideline just published 2 months ago. So it includes TAB, or it can be TDF or TAB, or plus FTC or 3TC plus DTG 50 milligram BID. So anyone want to comment on this regimen? Whether we should use TAB or not, or just go with TDF. And also, Irit, for your early slides, mentioned about DTG, QD dose. So how would you like advise us on that?
They're all hands. Let me do 2 microphones.
Okay.
Okay, I'll take it one at a time. So let's start with TAF.
So I don't know. I mean, TAF is very much available in the United States. I don't know about its availability in your countries, but it's very much available in the United States. And so the question is, but at the same time, the question is, what is the benefit of TAF? In other words, yes, maybe it's okay, but at the same time, why do we need to use it? I mean, it's part of most of our fixed dose single pills, and so maybe that's one reason. So in other words, we have to ask patients to take multiple pills, but they're also taking a rifampin regimen, so they're already taking multiple pills. Do you really benefit from reducing, 5 pills to 4 pills as opposed to 2 pills to 1, which I think there is an advantage. So I think you could delay initiating TAF. I mean, I would still tend to want to delay initiating TAF because unless you have a baseline, elevated creatinine situation that you're not happy with using TDF. So I think those are going to be pretty unusual situations. The dolutegravir 50 BID is an interesting question. I showed the slide earlier that suggested that there's not that much difference in there isn't really any significant difference in viral suppression achieved. The theory behind it, just so people know, is that it probably takes a higher level of a serum level of dolutegravir to suppress unsuppressed virus than it does to maintain suppressed virus. So one of the theories might be that, could you say that one of the things you could say is there any benefit to 50 milligrams BID in a person who's already suppressed? So you have a person who's already suppressed and then they get diagnosed with TB and you're putting them on rifampicin regimen. Do you need to now increase the dolutegravir, or because you've achieved suppression, could you keep it at 50 milligrams once a day, which I think you probably could, to be honest. I think the question that still is unresolved is, would you delay time to suppression of virus if you only gave it 50 milligrams daily in an unsuppressed situation? But then the other question you should ask is, what is the damage done by delaying to suppression? In other words, if it takes 12 weeks to suppress instead of 4 weeks to suppress, what happens? Are you going to get dolutegravir resistance in a matter of 8 weeks? I think it's unlikely. So I don't think there's a harm. I mean, it's not a particularly toxic thing to take dolutegravir 50 milligrams BID, so I think if patients can tolerate it, it probably would be something you'd want to do in an unsuppressed situation. But I'm pretty comfortable in a suppressed situation to not increase to twice a day.
Okay. So I asked this question because for Thailand, we have the fixed dose combination of generic TAF, FTC, DTG in a single pill. So in the case developed TB after using this combination, whether we should switch back to TLD or just continue with TAF, FTC, DTG. So. And also with the point that you has mentioned about the suppressed viral loads, maybe we do not need additional 50 milligrams. So actually I do agree with that. So look back at the history of treating ART with TB from effervescence. So we start with a higher dose effervescence, and then with standard dose, and then even now 400 milligram can be used with rifampicin. So I think maybe it's the same. And when we look back, the spring trial one, that they compare 10 milligram DTG, 25 milligram DTG, and 50 milligram DTG with effervescence 600 milligram DTG, and at 48 weeks. So the efficacy of suppressed viral load is not different between even 10 milligram or 50 milligram. But the company, they usually choose the higher dose, like effervescence. They choose like a 600, even 400 is not inferior to to 600. Yeah. So maybe if with that, and when we think that the rifampicin reduced dolutegravir about 54%, So then I think maybe in suppressed patient, maybe we can use just standard dose of DTG. And for TAP, so for the US guideline, they say that no, they should not recommend TAP. But I think for TAP, if we look at the study, using TAP with rifampicin, and then they look at the so the drug level decreased significantly, almost 50%. But when they look at the intracellular, so the level of tenofovir still about 4.2%, to 4, not percent, 4.24 higher than tenofovir level without rifampicin. So it means that it's with that. So maybe TAP can be safely used as well. So any comment on this?
Yeah, I agree, because when I see patients with tuberculosis and they have rifampicin in the regimen of for treating TB, I feel comfortable to give TAF, because I'm sure that the plasma level going to be down, but intracellular concentration is still high, because the action of NRTI is intracellular action, not the plasma level. It cannot be correlated. So I think if you are so sure that intracellular level of the drug is high enough to combat infection in the cell, can inhibit viral replication, I think I feel comfortable to give TAF with rifampicin.
Thank you very much. So any comment? No, right? So if no, go to the next slide. So just talk about the TPT. When look at this slide, so the risk of TB starting from HIV infection and increased significantly inversely with the CD4 cell count declining and the viral load increasing. So, and then you can see that the risk of active TB increased 2 to 5-fold soon after HIV infection, and especially higher if CD4 less than 200. And ART does not fully restore the risk to the baseline from the graph. So the risk of active TB remain more than 4-fold above the baseline, even after CD4 cell count have recovered. So if you look at this data, what do you think about the TPT? So just go to the next slide. So these are the recommendation from the WHO recently, and in September last year. So talk about the cascade of care approach to scaling TB and TB preventive treatment. So first, step 1, just identify those eligible for TPT. So not all. So just look at eligible patients, like classify to 2 groups. First, people at elevated risk of progression of TB disease, like with the host, poor host function, like HIV and organ transplantation, or the people at increased likelihood of exposure of TB disease, like household contact and healthcare worker. So, and then after that, you identify the eligible for TPT, and then step 2, clinical evaluation to rule out active TB disease. I think it's very difficult, especially for advanced HIV. They might have like a subclinical of TB diseases. So how we can rule out active TB? So, and then the next step is testing for TB infection. So as you can see here, so for IGRA test, so in Thailand we have the problem with the cold chains. So it means that they have more negative tests Then usually, for example, we did a study in prison with Sivaporn did that in 5 years ago. So we found that the IGRA positive was 61.6% in prison. But just recently, for the national data, they look at that, it's only 7% positive. So it means that IGRA even is good, but it has some technical problem. And how about whether we want to introduce the new method we call the M tuberculosis antigen-based skin test. So now the WHO endorsed from three companies from India, China, and Russia. And India is called CTB. So when look at the performance, so it's equally to IGRA test, but better than TST. And so do you have any comment on this? So the first, step 1, step 2, step 1, just look at or identify eligible patient. Step 2, clinical evaluation for active TB. Step 3, testing for TB infection. And step 4, the treatment. For the WHO, so now the prefer is isolasis 6 to 9 months. The 3HP, 3HR, HR is rifampicin. And with the newly approved is 6 months of daily levofloxacin for contact exposed to MDR or RRTB. And for alternative, for drug sensitive exposure is 1 HP or 4 months of rifampicin. So any comment on this guideline for the WHO? So I guess that many countries will be forced by WHO to follow this guideline, including Thailand.
Yeah, for us in Malaysia, in the place where I practice, we normally use a single agent of isoniazid. I think that's before the levofloxacin was in the guideline before this. And rifampicin is not available in my place of practice, hence the longer duration of isoniazid. So we start the patients on, PLH, people living with HIV, we start the isoniazid. And we do not do the TST because, again, it's endemic in Malaysia, so it's difficult to interpret when we do the TST anyway. So that's not a necessity for us to initiate the patient on isoniazid monotherapy for 6 months usually.
Okay, yeah. So it means that you don't test, but just treat.
Symptoms, we need to screen carefully.
I mean for if people with HIV,
yeah,
without active TB.
Yes, without active TB, yes.
Yeah, so you just go with
we will counsel
TPT,
them. Yeah, and TPT, yes. And the choice will be single agent, isoniazid.
Okay,
yeah.
Okay, yeah.
And so if they're asymptomatic, you don't do anything further to rule out active TB, you just start the TPT?
If they don't have any risk, like exposure recently and no cough, no night sweat, no loss of appetite, and so on, yeah, we don't.
Okay, I think for the TST here, we talk about the TB-specific antigen skin test. So I think we should, when look at the performance, so maybe, and also the cost would be cheaper than IGRA. And it's similarly to TST, just skin test, but in terms of performance, it's better than the old TST. So, but I don't know whether any country have experience using this test. Maybe not. Maybe
third test, the antigen?
The M tuberculosis antigen-based skin test.
We use IGRA, but cold chain is not an issue in the U.S.
Yeah.
So we use IGRA or T-Spot. Some places use T-Spot.
Yeah.
I was going to ask about BCG. So is BCG used here? So
for all babies.
Because we have a problem with people with BCG in the U.S. We have a problem with BCG because they receive their BCG outside of the U.S. because we don't give BCG in the U.S. but we have a lot of people in the US who receive BCG outside of the US, especially working in the healthcare system. So we do IGRA. We pretty much went with IGRA also because we feel like that overcomes that issue, but I don't know how you guys feel about it.
Okay.
We do have IGRA as well in Malaysia, but it's very costly. It's about $40 per test. So it's not reachable for many as well. So, and TST is not really helpful. So we go by, clinical and risk benefit weighing and initiate.
Yeah.
Yep.
So, okay. Gail, you don't have, because it's not your problem.
It's not my problem. Now, it's really interesting. Obviously, you're the experts. We have very little TB in Australia, although we do see TB, obviously, often in people who've come from endemic countries. So when we do test everybody, we do IGRAs at baseline in all our patients, but we certainly don't really do TPT generally.
Okay, so it means that now, so TPT is still debated whether we should give it or not. So when look at, even after ART, it seems like the patients still have higher the risk of active TB or reactivation compared to the baseline. So to the next slide, please. Just the next question. So TPT regimen. So the first question, whether we should have TPT for all HIV or not. And then the second question is that, what's the regimen? So actually, I don't put the levofloxacin because just focus on drug exposed to drug sensitive TB. So now actually for Malaysia, I think they have the fixed dose combination of isoniazid with rifapentine, and also this all from lupin or macross. So they have the fixed dose combination.
Yes, we
it's
do.
It's not that expensive.
Isoniazid and rifampicin, I think it's not expensive.
This is isoniazid and rifapentine.
Rifapentine, I'm not
It's
too
not
sure
expensive as well. So you can talk to Mylan outside. So just give the same cost with the Thailand. Yeah. So then we can so we can use it in Malaysia or even I don't know.
Yeah, I will quote your name, Dr. Anjali.
Oh
Hopefully
yes.
Hopefully you can get some good deal.
Yeah, and many countries as well. If you want the shorter cost of a TPT, so you can use either 3 HP or 1 HP. So in the past, the WHO still recommend that DTG with 1 HP. So DTG should increase the dose, but just recently, so no dose modification. So it's made very easy whether you can you use a 3 HP or 1 HP. So you can use with 1 pill of TLD regimen. Yeah, and for 1 HP, it's just only 78 days. But for 3 HP, it's weekly for 12 weeks. So it's easier. But for 3HR, I think for HIV, it's quite difficult because you have to increase the dose and DCG, or even you use with the QD dose as an active TB. And also, but 3HR, so for me, I recommend for healthcare worker, because for the nurse, especially the nurse, they usually have higher risk of rifapentine hypersensitivity. For the women and older than 35 of age, many nurses meet that criteria. So I don't know. Just ask your opinion on this before we.
I think the only thing I can comment on, and maybe we should be asking Mylan this, but is that I'm not so sure if, I know from a PEPFAR perspective, I still question whether if in PEPFAR supported countries, if 3 HP or I don't think we're looking at, or 1 HP becomes the standard, is there enough global supply to meet that standard? I think I'm not so sure there's enough manufacturing right now to meet that standard. Like if you think about, maybe there may be 10 or 15 million people with HIV in the world who would benefit from a TPT regimen, and I don't think there's that much 3HP in the world, whereas I think there is enough isoniazid.
Okay.
So that probably will continue to be a consideration. I think cost-wise it is a little more expensive, but I'm not so sure that it's that much more expensive for the course, since it's a shorter course. And I think, PEPFAR and Global Fund have done a good job negotiating pricing on it.
Okay, thank you. So just go to the last slide if no one. So I think for since active TB is still very common in our HIV patient, so we should complete the cycle like active case finding, treat early, and also prevention. For prevention, it's not just TPT, like same day or rapid ART for all HIV patients, and also for those without active TB, using TPT, and also with other like a diabetes control, smoking, something like that. So in near future we might have TB vaccine. So I don't know how long we're gonna have that to prevent active TB. Okay, so any comment from the floor or question? Everyone want to go home, go shopping. Okay, so if okay.
Okay. Hi everyone. My name is Anh Ho from the TB team in the US CDC in Vietnam. It's very interesting that in this session you mentioned about the urine lamp, because last year we also started the demonstration of urine lamp among people living with HIV funded by PEPFAR. And we often receive somehow like a discordant results feedback from the clinicians. For example, many cases have a AF lamp positive, but the expert negative, and they don't know how to do with that. Even though we already have include the WHO recommended algorithm 2A and 2B for CAP TB diagnosis among people living with HIV. It means that once the AF-LAM positive, they can initiate the TB treatment, but they still need to wait for the results of the molecular test adjust the regimen if necessary. So the question here is that how to build the confidence among the healthcare providers when they use the results of the urine lamp. So I don't know if any countries here have implemented this innovative test, and have you done any quality control of the test so that we can increase the confidence among the healthcare providers. It's the first related to the urine lamp. The second one I would like to share about the TPT among people living with HIV in Vietnam. So the way that we also follow WHO guidelines. We know that in Thailand, you do the screening for the latent TB infection among people living with HIV before you make decision whether you initiate TPT or not. But in Vietnam, like in Malaysia, we initiate TPT for anyone. First of all, before the new guidelines from WHO coming out, we rely on the TB symptom screening. If negative, we will initiate the TPT. But with the new updated guidelines for TPT I think in 2020, right? So in 2021, the Vietnam MOH right away updated the guidelines, and they also work around different, let's say, TB screening algorithm. and rule out, so not just only screening for by using the TB symptom, but also for high-risk population, for example, the naive AT patients, those who have retreated after default, or those who have like a treatment failure, will be, let's say, if they are asymptomatic, they need to be screened by either CRP or chest X-ray, and if negative with those alternative TB screening, they will be ruled out for TB, and they will be eligible for TPT. So I think that we need to combine both approach of using the TB screening algorithm, and then to make decision for eligibility for TPT, and also detect TB among people living with HIV. Yeah, thank you.
Thank you very much. Very good question. Who want to respond first?
I'm just wondering if anyone knows what this, to her point about the urine lamb, does anyone know what the standard was? I assume it was not gene expert. It probably was TB culture, I assume. Was it not?
Yes, standard is a culture for TB.
So I think the question is, a discordant result of a urine lamb positive and a gene expert sputum, I assume, negative, doesn't rule out TB, correct?
Yes.
No, because the sensitivity of the gene expert ultra, so with the among HIV is lower than non-HIV, and especially in people who have very low TB burden. So the sensitivity is lower, so it's about 60 to 70%. It's not like a 90%. So it means that in the people who have negative gene expert, it does not rule out active TB. And again, for urine lamb, so the sensitivity is quite low, but if it's positive, but the specificity is not 100%. So it depends on the symptom, I guess. So if the patient have symptom, fever, or any symptom, so if urine lamb positive, just treat for TB and waiting for the culture or the clinical response.
I think that we should incorporate the clinical information with the test, because if the test is negative, but likelihood of having something, you may give empirical treatment for tuberculosis and wait for the culture, and then if the culture come back, you know it's false negative, false positive. But don't forget to use the clinical judgment to help you select for the appropriate treatment.
I would like to say like the TB LAM and the rest of the tests will be an additional tool for us to clinch a diagnosis. It's not like do it or, it's not a yes or no kind of, to sort of, yes or, do or die, that kind of scenario. We have to put all the clinical scenario together and see how high is the likelihood of TB. Although all of that may be negative, we have to proceed to the next step of investigation. For example, a bronchoscopy may be needed to get a better sample for testing, so things like that, yeah.
Yeah, so if you ask about the guideline from TUC, support the urine lamb for Thailand. So about 3,000, maybe Dr. Langsima can comment on this. So she very supportive for the TB program.
Okay, so I'd like to share two topics. The first one is about ULI-LAM implementation in Thailand. CDC, PEPFAR, in collaboration with HIV-NAT and the Ministry of Public Health, we pilot the ULI-LAM implementation in 2021 to 2023. And there were about 2,000 patients in our database, and based on the data, it aligned very well on the slide in terms of sensitivity and specificity that Dr. Anjali showed earlier. And we found very positive response and satisfaction from healthcare providers in Thailand. They provide such a very positive that they love this test and it can be used as additional test, particularly in some of the community hospital or district hospital that far away takes some time in order to get a turnaround time for gene expert diagnosis. And based on this, Dr. Sairat from the Ministry of Public Health presented this data to the National AIDS Committee and requested for including this into the Universal Health Coverage Scheme. And we luckily that the National approved this in the National AIDS Program. But this year to next year, we in the transition period in terms of support in the national program. So PEPFAR continues support about 3,000 tests by collaborating with the Ministry of Public Health for the ULILAM, and we plan to pilot it in the 14 PEPFAR supported provinces for this year. And we'll use as additional tests. And we also found some cases that report as doctor from Vietnam that they discontinue TB treatment after ULILAM positive and they initiated TB. But we have to take a look in the database, what are the cause for discontinuation of treatment. This is one thing. For the second one, I'd like to share about our experience for TPT implementation for short course TPT 3 HP and 1 HP implementation in Thailand. We work with the Ministry of Public Health, analyzed the national database from 2022 to 2023 and 2024. There were about approximately 4,000 cases in the database, and of the 75%, around 75% of them received 3 HP. And very interesting that the completion rate was very high for 1 HP. For 1 HP, completion rate was about 93% and 3 HP about 85%, and very few side effects. So it's very promising for moving forward in the future to empower all the healthcare providers in Thailand to initiate TPT. Yes. Thank you.
So any comment? So thank you very much, Dr. Langsima. So it's the time. Oh, so I promised to finish earlier, but it's all time anyway. So sorry for that. Thank you everyone for joining this very interesting case. And I would like to thank all the panel. Just give them the applause. Thank you very much, everyone. We are enjoying this discussion and also gain some knowledge and practice. So have a good night today and enjoy Bangkok, enjoy shopping and food for tonight, for evening. So thank you so much, and see you all tomorrow section. Bye bye นะคะ ค่ะ สวัสดีค่ะ